This explainer is based on Anxiety-Related Dizziness, a Vestibular Physician Deep review of panic disorder, generalized anxiety, and hyperventilation syndrome published by Australian Dizziness Clinics.
Welcome! I'm absolutely thrilled you're here because today we're diving straight into something that shows up in the clinic practically every single day, yet it still gets incredibly misunderstood. We're unpacking the 3 core clinical phases of anxiety-related dizziness, and we're going to connect the dots on the multisensory deficits that tie them all together. If you're working at the deep end of functional and psychiatric vestibular practice, distinguishing these phenotypes isn't just helpful, it's absolutely crucial.
Okay, here's our rapid-fire roadmap. We'll cover core clinical phenotypes, panic disorder, generalized anxiety, space and motion discomfort, the hyperventilation cascade, and finally, key takeaways.
Starting off with Section 1, core clinical phenotypes. Let's get our mental framework locked in for the 3 primary ways this actually walks into our clinics. Broadly speaking, we're looking at 3 distinct buckets. First, you've got panic disorder, which hits with these discrete, completely unpredictable attacks. Then, there's generalized anxiety disorder, or GAD, which drives a much more chronic, persistent unsteadiness. And finally, we have hyperventilation syndrome, a distinct physiological trigger that can either be provoked episodically or just sort of hum along as a chronic pattern. Getting this framework down is really step 1 for locking in an accurate diagnosis.
Moving to Section 2, panic disorder. Let's put those episodic spikes under the microscope.
You know what's truly fascinating? It's how remarkably close panic disorder can mimic a peripheral vestibular attack. Sure, it's defined by recurrent, unexpected panic attacks, but here is the critical stat for us vestibular clinicians. Dizziness is reported in 65 to 80% of these episodes. It's literally one of the most common somatic symptoms, right up there with palpitations, shortness of breath, and those tingly paresthesias. Because this entire cluster looks so much like a peripheral vestibular event, these are exactly the patients getting bounced to us from the emergency department, from cardiology or neurology, usually after all their ECGs and scans come back perfectly normal.
Right, Section 3, generalized anxiety. Let's shift gears from those acute spikes over to the persistent symptoms. In the vestibular clinic, GAD usually shows up as this everyday sense of rocking or floating, just a chronic background unsteadiness. Now this heavily overlaps with persistent postural perceptual dizziness, or PPPD. Actually, a ton of patients meet the criteria for both at the exact same time. This chronic dizziness, it's basically maintained by a mix of perpetual low-level autonomic arousal, heightened somatic hypervigilance, where the patient is just obsessively monitoring their own vestibular sensations, and of course the downstream consequences of avoiding triggers.
Which brings us perfectly to Section 4, space and motion discomfort.
So what's the thread pulling all these different presentations together? Space and motion discomfort. How many times have you heard a patient say, I get dizzy in supermarkets, on escalators, and when I'm driving on motorways? If you spent even a week in a vestibular clinic, you know this exact phrasing, right? This classic history is the clinical signature of space and motion discomfort. It brilliantly highlights how environments that bombard you with excessive or conflicting visual vestibular input just instantly trigger severe spatial disorientation and fear.
And it's so vital to grasp that this isn't simply anxiety avoidance. Space and motion discomfort represents a genuine, neurophysiologically real perceptual deficit in multisensory integration. These patients have an abnormally sensitized vestibulo-anxiety circuit. Their elevated norepinephrine is actually ramping up their vestibulo-ocular reflex gain. So explaining this mechanism to the patient isn't just you being nice, it's a profound therapeutic intervention. You're looking them in the eye and saying, your symptoms are real and they are not imagined.
Okay, on to Section 5. The hyperventilation cascade. Let's dig into the mechanistic funnel of hyperventilation syndrome.
Think of this as a powerful, relentless positive feedback loop. A psychological stressor kicks off the hyperventilation. That overbreathing immediately leads to escalating vestibular symptoms like dizziness and visual blurring. And what happens next? Well, that very dizziness generates even more anxiety and fear, which feeds right back into, you guessed it, more hyperventilation. It's a totally vicious, self-sustaining cycle. Let's actually break down the physiology of why this happens.
When you trace the cascade step by step, the physical symptoms make perfect logical sense. Step 1, you get rapid or deep breathing, overbreathing. Step 2, this tanks the arterial partial pressure of carbon dioxide, throwing the body into a state of hypocapnia. Step 3, that low CO2 instantly triggers cerebral vasoconstriction. And step 4,
In severe cases, cerebral blood flow can plummet by roughly 30%. That massive drop in perfusion directly causes significant dizziness, lightheadedness, and visual disturbances.
But hold on, hypocapnia is only half of the story. At the exact same time, that drop in CO2 kicks off respiratory alkalosis, and this alkalosis actively lowers the levels of ionized calcium in the blood. So what does low calcium do? It ramps up neuronal membrane excitability. That is precisely what's causing those classic perioral and extremity paresthesias, the tingling around the mouth, the hands, and sometimes even those terrifying carpal pedal spasms. When a patient feels their hands locking up while the room is spinning, they are convinced they're having a stroke. But it's literally just the direct neurochemical result of alkalosis.
Now here's the part that is just incredibly cool for us vestibular specialists. The vestibular afferents themselves are not immune to this entire cascade. The differential alkalosis-mediated changes in nerve firing rates can actually unmask a pre-existing latent vestibular asymmetry. This creates hyperventilation-induced nystagmus, or HVIN, meaning hyperventilation isn't just pretending to be a vestibular symptom, it's literally provoking a measurable vestibular reflex by altering the neurochemistry of the labyrinthine efferents. How wild is that?
Because this mechanism is so predictable. Doing a voluntary hyperventilation provocation test in the clinic, having them do 30 breaths per minute for 3 minutes is absolute gold. It is both diagnostic and deeply therapeutic. By safely recreating their exact symptoms right there in your chair, and then resolving them with slow diaphragmatic breathing, you are giving them undeniable physical proof of the mechanism. You validate the reality of their symptoms, especially for the skeptical ones, and you prove to them they actually have the power to control it.
Bringing us to Section 6, Key Takeaways. Let's lock this clinical understanding in.
So what are the big takeaways from this explainer? Make sure you distinguish the episodic, unprovoked attacks of panic disorder from that daily, chronic unsteadiness of generalized anxiety disorder. Recognize that space and motion discomfort is a genuine unifying perceptual deficit, not just avoidance. And finally, definitely utilize voluntary provocation testing. It's a definitive diagnostic and a brilliant educational tool for the hyperventilation syndrome cascade.
So here's the provocative question we're left with. If these phenotypes mimic structural disease so perfectly, how do we confidently rule out the dangerous stuff without falling into the trap of endless over-investigation? Well, join me in Explainer 4, Diagnosis and What to Exclude First, where we'll turn these phenotypes into a positive diagnosis. For additional resources, including the full literature review, clinical cheat sheet, and patient leaflet, head over to AustralianDizzinessClinics.com. And hey, please subscribe to support the channel.